This diagram is out of a Porth Pathophysiology book. I like it because it's a nice picture of all the different components that the kidneys control. And it gives you kind of an overview of the different aspects of the comorbidities that can happen with chronic kidney disease. So a lot of these comorbidities happen as you approach stage 3, 4, and 5 into renal failure. And the expectation is that you would work with nephrology. So we'll go over the pathophysiology of this and the different treatment plans to expect. But your role as a primary care nurse practitioner is to really monitor, screen, and work with nephrology as these stages become more complicated. This table will help you to understand the etiology and some of the treatment approaches for acute versus chronic hyperkalemia. Acute hyperkalemia can certainly happen in the primary care setting, and you should expect assistance with acute care practitioners. The definition of hyperkalemia varies depending on the lab and has limits such as greater than 5.5, greater than 6, greater than 7 to determine the severity. Repetitive consecutive measures of serum potassium are needed to determine if hyperkalemia is sustained or is a transient event. Many factors do affect potassium homeostasis. So hyperkalemia is often asymptomatic, but patients can complain of nonspecific symptoms such as palpitations, nausea, muscle weakness, muscle pain, some paresthesias. Moderate and especially severe hyperkalemia can lead to cardiotoxicity, which I'm sure you're all aware of, and this can be fatal. The cause of hyperkalemia has to be determined to prevent further episodes, regardless if this is acute or chronic. Hyperkalemia can cause life-threatening arrhythmias, and organ effects of hyperkalemia are more significant if hyperkalemia develops quickly, and that is a common rule for many things that we manage. Things that come on quickly seem to be more life-threatening at times. Life-threatening hyperkalemia occurs more commonly when there is acute on chronic kidney disease. The impact of renal failure on potassium excretion is most significant when there's concurrent potassium intake or the patient's taking medications that can cause high potassium levels. There could be reduced urinary potassium excretion, so all these things we must consider. An example of aldosterone type medications and their impact on aldosterone receptors is something to be aware of. So this table will help you understand the etiology and the different treatment approaches for acute and chronic hyperkalemia. Acute hyperkalemia can certainly happen in the primary care setting, and you should expect assistance with an acute care practitioner if you have significant symptoms or significant elevations in your potassium level. So the definition of hyperkalemia actually varies depending on the lab. It's anywhere from greater than 5.5 to greater than 6, greater than 7. We do repetitive consecutive measures of serum potassium to determine if the hyperkalemia is sustained or a transient event. Many factors affect potassium homeostasis. Chronic kidney disease is just one. Hyperkalemia is often asymptomatic, which makes this a little bit harder, and you have to be suspicious depending on the medications and the different medications that your patient is taking. Patients may complain of non-specific symptoms, such as palpitations, nausea, muscle pain, muscle weakness. Sometimes they have paresthesias. I'm sure you're all familiar with hyperkalemia symptoms. Moderate and especially severe hyperkalemia can lead to cardiotoxic situations and can be fatal. The cause of hyperkalemia has to be determined to prevent further episodes, and that will be part of your job. Hyperkalemia can cause life-threatening arrhythmias, End organ effects of hyperkalemia are more significant if the hyperkalemia develops quickly, and we know that holds true for many things like anemia. If that happens quickly, it's more concerning. Life-threatening hyperkalemia occurs most commonly when there is an acute on chronic kidney disease. The impact of renal failure on potassium excretion is most significant, with concurrent potassium intake or drugs that reduce urinary potassium excretion, such as aldosterone receptor antagonists. These are all pieces to the puzzle that you must put together when working with patients that are at risk for hyperkalemia. So potassium can be controlled really through 4 different mechanisms. You can stabilize the membrane, you can redistribute the potassium, there can be excretion of the potassium, or elimination completely with the use of dialysis. We already talked about the cardiotoxicity and the different signs and symptoms. From an EKG standpoint, just a reminder that we often see peak T waves. You can have prolonged PRL intervals. Sometimes there's just a flattening or maybe no P wave altogether. Sometimes you'll see a wide QRS. This hyperkalemia, if it's significant enough, can contribute to ventricular fibrillation and even asystole. Here are some examples of acute management of hyperkalemia. This is provided by the National Kidney Foundation. I don't expect that you would be prescribing this kind of treatment, but I wanted to share it with you. The more likelihood of you prescribing a loop or a thiazide diuretic makes more sense to me, but I wanted to share this with you anyway. Here are some examples of treatment for hyperkalemia in the primary care setting. What I've seen most common is the prescription for a loop-type diuretic. So either the loops or the thiazides will work. There is an option to use some type of laxative, like the biscotal products. You can use a cation exchange product, but probably the most common one seen is a loop or thiazide type diuretic. So we have a lot of studies that show that the ACE inhibitors and the ARBs are very helpful to people with chronic kidney disease, and that reduce the risk for kidney failure, they reduce the cardiovascular events, but they do pose a risk for hyperkalemia, especially as you get in the later stages of chronic kidney disease. So the Kidney Disease Improving Global Outcome sets the guidelines that we do want to prescribe an ACE or an ARB, not together of course, with patients especially who have diabetes and chronic kidney disease when their albumin creatinine ratio is between 30 and 300. We also want to use an ACE or an ARB in patients with diabetes or non-diabetic patients with chronic kidney disease when their urine albumin is greater than 300. And you'll note neither one of these say that a patient actually has hypertension. These are renal protective drugs. So as you place your patient on an ACE inhibitor or an ARB, you may want to consider just checking the electrolytes a few weeks after you start to make sure that they aren't developing hyperkalemia, specifically to the patient that has some chronic kidney disease. I think it's important to educate your patients on foods that have high potassium and encourage them to avoid those types of foods. This is a great slide. In fact, you could use this to hand to your patients to help them with understanding what foods to stay away from and what foods to enjoy. I think having a collaborative partner in dietary is very helpful. I also think nurse practitioners can do a really good job here in helping patients with nutrition. So please take the time to learn some of the high potassium foods and some of the lower potassium food choices. Chronic kidney disease, mineral bone disorder is a major area of concern for the end stages or the later stages of chronic kidney disease. As a primary care nurse practitioner, there are certain things that you're going to want to monitor, but you're going to work collaboratively with nephrology in this area. It gets kind of complicated. Even nephrologists find this area challenging. So it's a systemic disorder of the mineral and bone metabolism due to kidney disease. And you can have abnormalities related to calcium, phosphorus, parathyroid hormone, vitamin D metabolism, which we can monitor, no problem there. But you can also have abnormalities of bone turnover. This mineralization can be an increase or decrease, so it makes a difference on how the patient is treated. Then if you treat the patient with calcium, then there's concern for vascular and other soft tissue calcification issues that we start to worry about. So it becomes quite complicated. So when you look at the markers for bone health, you can see from this graph that there's a steady decline of your vitamin D3. The dihydroxy vitamin D and the hydroxy vitamin D are a steady decline. You'll see an inverted relationship with your parathyroid hormone, especially as your GFR approaches 30. That seems to spike up pretty steadily. Okay, let's see if we can make sense of this graph. This is showing us chronic kidney disease and the mineral bone disorder that goes along with it. If I were to put this in a nutshell, it's simple as this. Healthy kidneys remove extra phosphorus from the body. When you have kidney disease, the kidneys cannot excrete the extra phosphorus. Extra phosphorus pulls calcium out of the bones, making them weaker. Higher phosphorus and calcium may settle into your blood vessels and into your heart. This causes calcification, or hardening of the arteries, hardening of the heart valves. As the kidney function declines, there's progressive deterioration in mineral homeostasis, with disruption of normal serum and tissue concentrations of phosphorus and calcium. And there's changes in circulatory levels of hormones as well. These hormones include parathyroid hormone and the different vitamin D metabolites. There's also a fibroblast growth hormone called FGF23 that is altered. So the ability of the kidneys to excrete phosphate is diminished, leading to hyperphosphate anemia, so more phosphate in the blood. The kidneys also have inabilities to convert your D325 to your 125 D3. Those are vitamin D components, also called hydroxycholecalciferol or dihydroxycholecalciferol. With the decreased ability of those hormones to convert, there's an overall reduced vitamin D reactor activation in the parathyroid gland. This causes an increase in the parathyroid hormone. So with a decrease in the excretion of phosphate from the kidneys, an increased reduction of absorption in the gut, a decreased absorption of calcium in the gut, it changes the serum calcium and serum phosphate levels, which all interplay with the parathyroid hormone. I hope that was helpful. This graph is from the National Kidney Foundation that's showing you the different biomarkers for chronic kidney disease mineral bone disorder. At the top you can see you have the red, which is the growth hormone, FGF23. The bluish purple is the vitamin D125. The green is the parathyroid hormone, and the purplish color is the phosphorus. And across the bottom is your GFR. So you can see that the earliest detectable alteration in mineral metabolism in chronic kidney disease is increasing circulations of the fibroblast growth factor, the FGF. That happens early. In this graph, it's showing you right around a GFR of 75. Elevated FGF23 also is an independent risk factor for progressive kidney disease in patients with chronic kidney disease and a predictor of mortality in patients with chronic kidney disease. So this is a marker that nephrologists will keep an eye on. FGF23 production is stimulated by phosphorus retention as the kidneys become less able to handle the phosphorus load. Gradually increasing FGF23 levels causes a decline in the 125 dihydroxy vitamin D levels, followed by a reduction in serum calcium levels and elevated parathyroid hormone secretion. So this pathological sequence of events occurs long before increases in serum phosphate levels are even evident. So this puts our patients at risk for bone abnormalities, including bone fractures. Also, remember from the last slide, I talked about how you can have an increase of calcium that can contribute to vascular calcification. So loss of calcium happens early in chronic kidney disease. Low vitamin D happens because of poor production and poor absorption from the gut. You get bone disease, soft tissue calcification, vascular calcifications. Low calcium leads to a rise in parathyroid hormone levels, so you can expect low calcium, high phosphate levels, and a low vitamin 125 vitamin D, or hydroxy vitamin D levels. The way that we manage this is by monitoring these different levels and then supplementing them with medications. As with many chronic conditions, therapeutic decisions are based upon trends, right? Not just on a single laboratory value. So when you're screening for chronic kidney disease mineral bone disorder, begin usually at stage 3 with a GFR anywhere between 59 and 30. The patient should be working with a nephrologist as you approach, a GFR of 30. We've talked about that quite a bit. So you can expect to collaborate with a nephrologist on the treatment plan and understand the rationale for each treatment plan. To understand the true effects of what's going on with the bones, the only way to do that maybe is with a bone biopsy, which happens very rarely, but it is a possibility. On this table, we have the different biomarkers for you and the different stages of when we monitor for each one. We hope this is helpful to you. The National Kidney Foundation recommends we supplement our vitamin D with 2,000 units of D3 every day, as this is more absorbed and more affordable. They also recommend that we understand what foods have high phosphorus in them and we limit our intake of phosphorus. Many times patients as they progress are going to need a phosphate binder, and please note that a DEXA scan is probably not going to be very helpful in predicting a fracture in patients with later stages of chronic kidney disease. Phosphate-restricted diets in combination with oral phosphate binders are well-established treatments in the management of hyperphosphatemia. Counseling patients about the hidden sources of phosphate, such as additives and preservatives, as well as the protein source, may improve serum phosphate outcomes. A study that focused on protein sources showed that patients who consumed vegetarian diets had lower serum phosphates and lower FGF23 levels as compared to those who were on a meat diet, even though the protein and phosphate content of the diets were the same. There are several risks and limitations associated with phosphate binder treatments, and you should be aware of these. So, for example, aluminum binders are known to cause aluminum toxicity. Calcium salts, including carbonate and acetate salts, are used frequently, but evidence suggests that the chronic use of these high doses is associated with vascular calcifications. We kind of talked about that in our previous slides. Calcium also raises the FGF23 level. Dietary calcium should be carefully assessed before adding to a calcium load. Meta-analysis show that non-calcium-based binders are associated with decreased risk of all-cause mortality compared with the calcium-based binders. So we have newer studies and we have products called iron-based phosphate binders that are showing promise and may help with some of the iron deficiency that happens in chronic kidney disease, as well as lowering some of the phosphate levels. You probably should know that 83% of patients that are on dialysis take some type of phosphate binder, and adding phosphorus is worse than a natural phosphorus, so like preservatives and things like that. Almost all foods have some phosphorus, but it's important to avoid foods that are known for high phosphorus levels. So the additives in packages and processed foods and beverages that add flavor and preservatives are probably the worst for you. It's better to have fresh food. Milk is high in phosphorus, so we usually limit milk to about a half a cup a day, and we prefer the unfortified or almond or rice type milks. The National Kidney Foundation provides a lot of handouts that you can give to your patients to help with education. Here's just an example of one that talks about veggie proteins and whenever possible to avoid fast foods because they're high in phosphorus and in sodium. Anemia becomes more common as you enter the later stages of level 3 chronic kidney disease, and that's because of a decreased production of erythropoietin from the kidneys. And you would expect a nephrologist to order some kind of stimulating agent to promote the production of erythropoietin. You can also expect any correction of iron deficiency. Iron deficiency frequently coexists with erythropoietin deficiency because of frequent blood draws, maybe because of poor nutritional intake, if you're on dialysis, certainly from the dialyzer. You always have to watch, though, to make sure that there isn't any gastrointestinal blood loss or other causes for lowering of the blood count. So malnutrition in chronic kidney disease is a significant problem. So the recommendation is that we work collaboratively with nutritionists. I also think that nurse practitioners are very good at nutrition and have a sound understanding of nutrition in general. So there's a few specifics with chronic kidney disease because we know this is a protein energy wasting type disease, and then there's a balancing act with how much protein they really need to not create a kidney burden. So this slide shows you the parallel rise in gout and chronic kidney disease, and has led investigations to the study of their relationship, including a retrospective cohort study based on 54 years of follow-up data from the Framingham's Heart Study, which found that an increased risk of developing gout and chronic kidney disease doubled compared to subjects not having chronic kidney disease and gout as a baseline. This difference remains significant after adjusting for all other gout risk factors. So gout has been steadily increasing worldwide. It is now one of the most common types of inflammatory arthritic type diseases. In the United States alone, its prevalence rate is more than doubled between 1960 and 1990 and is estimated to be at 3.9% of the U.S. adult population. Hyperuremia is also common, with a prevalence rate of 6 to 8% in healthy adults and a prevalence rate of 1 in 3 adults who have uncontrolled hypertension and several cardiovascular risk factors. Concerning the prevalence rate of chronic kidney disease has been increasing, with an estimated rates at 14% of the adults in the U.S. population and 8 to 16% globally. So both very significant diseases, and you can see their relationships, although we don't have a clear understanding of the cause and effect. So hyperuremia and gout are other conditions that are associated with chronic kidney disease. In fact, chronic kidney disease is the third most common independent factor for gout after obesity and hypertension. The pathophysiology of chronic kidney disease and gout is really poorly understood at this point, and we have studies looking at hyperuremia as an independent factor in kidney function itself. So epidemiological studies have addressed the association of hyperuremia and the prevalence and worsening of chronic kidney disease, and they've looked at, through the U.S. renal data system, over 177,000 patients over 25 years. And subjects within the highest quartile of serum uric acid had a hazard ratio of 2.14 for chronic kidney disease. So that level of risk ranked third for proteinuria after obesity and hypertension. Although they can't really make a causality relationship between the two because these are observational studies, there's still some kind of association between chronic kidney disease and elevated uric acid levels. So the non-modifiable risk factors for gout are male gender, increasing in age, or postmenopausal. About 15% of uric acid is cleared in the GI tract. You also can have increased uric acid level related to certain medications such as loop and thiazide diuretics. When you eat meat and shellfish, lots of alcohol or fructose, you're going to have increased uric acid. And we know that if you're obese, you have a 3-fold increased risk of developing gout. So there are no hard and fast rules on what your uric acid level should be, mainly because every lab probably has a different level of normal. The recommended serum uric acid level should be low enough to effectively improve and maintain signs and symptoms of gout. And for most people, that's less than 6 milligrams per deciliter. The 2 first-line options for urate lowering therapy are the xanthine oxidase inhibitors and the febuxostat or allopurinol agents. The febuxostat does not require renal dose adjustment in mild to moderate chronic kidney disease. Because insufficient evidence exists on its safety in stage 4 or lowering levels of chronic kidney disease, no recommendations were issued for febuxostat in those settings. In chronic kidney disease, the starting dose for allopurinol should not be more than 100 milligrams a day in moderate to severe chronic kidney disease, followed by a gradual upward titration of the maintenance dose, which can exceed 300 milligrams a day. I recently had a patient who has chronic kidney disease and recently had an MI. He is asymptomatic with just barely elevated uric acid levels. The recommendations for him were to not treat but to monitor closely, because there is some concern with treating with a xanthine oxidase inhibitor and its impact on the kidneys. The American College of Rheumatology recommends prophylaxis when initiating urate lowering therapy because of the rapid decrease in serum urate can cause like a flare of gout. So first-line options are low-dose cocaine, 0.6 milligrams orally once or twice daily, with lower doses for moderate to severe chronic kidney disease. And then a potential drug-to-drug interactions, you got to watch for those. So although low-dose non-steroidal anti-inflammatory drugs such as naproxen are recommended by the American College of Rheumatology, they are not recommended by nephrology and should generally be avoided with any level of chronic kidney disease. So once again, for patients that have chronic kidney disease, you may not want to prescribe the NSAIDs for them for pain control. You might be better off going with the choline at 0.6 milligrams once or twice daily. Okay, and that wraps up our 3-part series of chronic kidney disease. I leave you with the 7 steps of caring for patients with chronic kidney disease as recommended by the National Kidney Foundation.